Okay, so here's our first recorded video for Psych610. And this is a presentation I gave. I'm going to just talk over the slides. Parts of this are relevant to this class. All of it's relevant if you want to work with PTSD, trauma victims. But I'm going to select specific pieces, and I will inform you as I go through it, that are relevant for the beginning of this class in particular, and setting the stage. Before we get into counseling, I want you to understand some of the basics about um, how to conceptualize change, why people change, why they don't change. And based on my research and interests and readings and beliefs, this summarizes it. Okay, so here we go. Let's see how this goes. Um, a lot of clicking here. All right, so this was my area of interest for a long time. Now I've switched more to homelessness and low income. Why we can't get people out of poverty. There's lots of other reasons, larger reasons, social justice issues, um, societal issues, whatever. But this, in terms of when you're dealing with an individual, these are some things to keep in mind. Although those things you have to keep in mind also when we are going to talk about that at some point, okay? So, in general, trauma victims in particular, but really anybody, what you have to be aware of is that people have trust issues with counselors, authority issues, confidentiality, the vulnerability of being in front of a professional, especially a mental health professional, not wanting to depend on others. These are all things that, and everything I talk about today and at different points in the class, will really put you to ninja level to be a counselor. And you'll understand more of that later on. So some of the trauma specific things, I'll let you read them on your own in the slide presentation here. If you're interested, we can talk about them. But I'm going to just cover and talk about the things that relate to treatment engagement in general. Okay, how to improve treatment engagement in counseling that the client, patient, the customer, as some organizations will make you say, why are they not engaged in counseling? Okay, so one of the words that I want you to start to use is barriers. People have barriers to treatment and engaging in treatment. And of course, that means barriers to successful treatment. Now, Treatment Alliance is going to be a critical thing that we cover this semester. But there are other things that we may not spend so much time on that I'm really going to just give it to you in an early dose here, is being aware of a client's treatment expectancies and fears about treatment. Okay, so there's three main categories of why people don't accept help, basically. Okay, first of all, they might be saying, what problem? I don't have a problem. This literature is critical. So we're going to call it problem acknowledgement, readiness to change. All right, and people are at various levels of readiness to change and willing to admit problems to themselves or other people. Okay, so that's one reason why people don't engage in counseling or accept help. The other set of reasons is people have certain fears and beliefs about what therapy is. Most people, their exposure to treatment is on TV, and I think every single show I've ever seen depicting a counselor is just horrendous. It's horrendous. It's not accurate. It might be accurate for some, but it's not good counseling at all, and it's not standard good counseling. Okay, so we're going to talk about each of these categories. And then the literature that we're going to talk about is expectancies about the treatment and patient role. All right. When they go into your counseling room, what are they expecting should happen? What is their role? So there's lots of that kind of stuff. The fourth reason is that therapists are poor at creating and maintaining treatment alliance. So I may say this again to you, but what happens is you go through school and you kind of learn the basics about what good counseling is. And then you get out in the world and you start doing your own thing. And you forget what in sports we would call the fundamentals. And you'll see this in sports where commentators will talk about, or coaches will talk about, like fundamentals. For baseball, everybody's got to know how to bunt. There's a certain way that you play what's called small ball, just getting people on bases. But there's fundamentals that everybody has to be good at, whether it's individual players' skills or coaching. And counselors, and I have found this to be true, tend to get lost in technique, or the other thing is, true for students too, to some degree, is you start to see or work for a therapist, like a supervisor. You'll have a supervisor who you think is really cool, says like amazing things to clients that makes them think and change, but stuff that's not standard counseling. It's clever stuff. Do not be seduced by that. That's when you start to lose the fundamentals and doing the basic things, because at the bottom of everything, your main goal in every session is just to make sure that client comes back for the next session. And the only way that happens is if you create and maintain a therapeutic alliance with your clients. And there's really one basic way to do that, or one basic method of doing that. And that's what's going to be this semester. There's going to be a lot about that. In some ways, it's the main thing this semester, whatever technical stuff we cover, okay? So, stages of change. This is Prochaska and colleagues developed this in the 80s, so to some extent the 70s, then the 80s. And what they came up with is a model called the stages of change. It's actually a small part of this longer theoretical thing they have that people don't really pay much attention to. But this, to some extent, has taken over the psychology field, and more so the clinical psychology field. It's amazing the counselors who are not familiar with this. This is essential for helping clients, because you're not going to get perfect clients. And supervisors don't have this stuff in mind. Not all of them, but some of them that you run into. You will be seen as, like I said, like ninja level therapist. People will consult with you. They'll want to send clients to you. They'll want to pay money to see you give talks. If you integrate this into your counseling, and you will become known for handling difficult clients, and that's something special. That's a real high level of expertise. I think we talked about managing careers a little bit, and that's an important one. So what they basically propose is that people are at different levels of readiness to change. Some of it's awareness, right? It's very specific to specific problems. So the PTSD thing I'll explain some other time, otherwise this will be 2 hours long. The key point is that at each stage of change, different interventions are needed at each one to get to the next stage. So an intervention to bump somebody from one stage to another is not going to work at a different stage. And I'll explain that, okay? So from now on, at least in front of me, you can never use these phrases. Never use the phrase in denial, never use the phrase resistant, and never say not ready to change. In my work, I'm trying to educate my colleagues in the community not to say things like, well, they must want to be homeless. Right? If you work with homeless, you know that so many are given opportunities and don't take them. So nobody wants to be homeless, and as you'll see in a moment why I believe that there's a different way we need to think about it. Okay? So even manipulative is another word I put on my banned phrases and words list for graduate students. Okay? There's a negative tone to it, and you need to be a counselor. You need to think like a psychologist. Psychologists look for reasons why people don't do things that are good for them. This is the basic stage of change model. I have warped this a little bit for myself. I think this is something they presented at some point long ago, and then I sort of just modified some things for PTSD, but it doesn't matter, okay? So you can fit anything in for PTSD. Alcohol consumption, anxiety behaviors, depression behaviors. There's a lot of stuff this applies to. It gets mostly applied to substance abuse, but there's, and other more health behavior things, eating, right? I mean, a big issue around here, especially in the African American community, is health, underserved, but I mean, true to some extent for everybody. So these are usually applied to health, but they can be applied to mental illness, and they can be applied in particular to homelessness and low income status. Okay, so 4 stages. And the way I have this, and I'm pretty sure that I took this way of doing it from Prochaska and DiClemente from some of their early work, is when someone's in pre-contemplation, they're not considering or not wanting to change. So they have a question. You can look at it like they have a question in their mind. What problem? I don't have a problem. What problem? So what your goal is to help them answer that question. Okay? Now, how do you help people answer that question who don't think they have a problem? And we're going to talk about why people may not think they have a problem. So the general issue is, what do you do? Now, if you get a client who's been referred to you for substance abuse treatment, I'm going to skip on this a little bit. You can't just start doing therapy with them. If they're in pre-contemplation stage, how do you think that's going to go? And we'll talk about that a little bit. So the best thing to do for people is you just educate them about what the problem is. You don't educate them about what their problem is. You educate them about whatever problem there seems to be some issue about admitting. Never confront them. Never try to talk them into it. And we're going to talk about motivational interviewing in a month, about how to do this. And again, what goes through all this is therapeutic alliance. If you start telling a person, well, you really are an alcoholic, look at all the things that have happened to you. What do you think the level of therapeutic alliance is going to be after that? You don't have to agree with them. Yep, no, I'm sure you don't have an alcohol problem. You don't have to do that either, but you've got to do this. You have to listen. And what you can do is you can say, well, okay, well, let's talk about what alcoholism is. Let me just go through some of this stuff. Give them some brochures. That might be what you do for 2 months. But you know what? They're going to come back every time. And your odds of saving them from dying of alcoholism or beating people up or killing people or, whatever else has gone up. Your odds of actually helping them avoid those things has gone up when you've done these things. So all you do, you listen, We talk about that. And you educate them about, well, let's talk about what alcoholism is. Hey, read this brochure. Let me know what you think. What do you think applies to you? What doesn't? That person's going to come back, probably. Certainly, they're more likely to come back than if you had said, well, let me tell you, come on, pal. I mean, really, look at all these things. I mean, 3 marriages due to alcohol. Yeah. So if you educate them, what you hope they will start to think is, huh, I wonder if I have a problem. Do you see? Really pretty small jumps here. I wonder if I have a problem. And now you've got them in contemplation state because at least they're considering maybe. All right. And the question now in their mind is, huh, do I need to change? So they're thinking about changing. This is contemplation stage. Now, when you think about something you need to change, drink less, change your diet, exercise more, spend less time in the sun at Myrtle Beach, use more sunscreen, be nicer to your partner. Am I too rough on them? Or personality thing. I get a lot of undergrads who just like feel like telling everybody how it is in their minds, giving them a little righteousness is like a good way to be. I mean, that's tough to deal with. But you know, aspects of your driving, right? You an aggressive driver? Be anything. Alcoholism. I'm not depressed. Well, I'm depressed, but it's not my fault. Um, I'm not OCD. I'm just super careful. I mean, um, I consider homelessness. I'm fine. I'm fine. I don't need any help. I'm just fine. Now, how do you change your behavior? Why do you change your behavior? You probably consider the pros and cons. Gaining weight, not feeling so good. Um, Geez, I got hospitalized for my last heroin overdose. Um, I missed work because of my drinking a couple of days this week. It's been happening a little bit more. What are the pros and cons, right? What are the pros to drinking? Makes me feel good. I don't have to think about my problems. Cons, I'm missing work. Your weight, well, I like my Oreos. They feel good. It's my stress relief. My weight is going up. You got to weigh this stuff. And that's pros and cons. The other thing you get people to do is you get them to think about what's average. I don't use the word normal usually. What's average? And most people have no clue is what's average. It's part of the reason they're not average on something. With my PTSD guys, like relationship stuff we talk about, and they wouldn't know like how's a man supposed to be in a relationship. I mean, how often do you tell your partner I love you? Um, I mean, everybody doesn't whack their partner every now and then. I mean, everybody doesn't miss a few days of work a month because of drinking. You got to get them. You can do this. There's a way to do this. I have this whole method that I'm not going to share. We're going to skip those slides, but I have an intervention that I actually used with PTSD, a group intervention that I've developed, and it was actually used in different in different VAs in the country. But anyway, we're not going to go into that. So if you get someone to analyze the pros and cons to what they're doing and compare them to norms, you might get them to say, you know what, I really got to stop eating those Oreos. Or I got to stop beating my partners up. Or being verbally abusive. Or maybe I've got to get off the streets in terms of homelessness. Now, once you get them saying that, the next question that's probably in their mind is, can I change? It probably seems overwhelming. So you think, yeah, I got to change, but how am I going to do it? It seems impossible. How I'm going to do it is not yet. But it's more of like, how is that possible? Someone can change. How can someone be not depressed? How can I not be OCD? how can I live without drinking? You know, most drug addicts, that's the thing you got to try to empathize with them. They cannot imagine going through the day, getting through a day without using. It seems impossible because of the urges or having to cope with things without it in their system. It seems impossible. Right? So when you get somebody who wonders whether they can change, this is where you expose them to peers who've had success. This is when you'd send someone with an alcohol problem to AA. Don't send them if they're not in preparation stage. This is preparation stage. Because they're going to come back, and I'll ask you in class if I remember, if you've known anybody who comes back from an AA meeting, they might say different things like, man, those people are really sick, or they just talked about alcohol, made me want to drink. But when you get somebody in preparation that stage, they're like, yeah, all those people did it. I know. Okay. So that modeling by peers would be exposing the peers, people who've had the same problem. And then you can also educate them about how counseling works and how counseling can help. Urge reduction, coping skills, social skills, whatever. And I'm jumping among disorders, but I just want to give you the general point. Hopefully you're going to see that. So you educate them about how people, well, how can just talking help me? Well, there's reasons why talking just helps you get some emotions out, helps identify things to work on, just feeling connected to someone else, sometimes is helpful. It's a big part of therapy. All right, so you educate them about what counseling is, whether PTSD specific, I could go on, but they don't understand. Why would I have to think about that incident again? A lot of the main treatments are, go back through the incident. Why would I go back through that incident again in my head? It was horrible. How would that help? It's just going to make me worse. Let me explain a theory of why. And that's why also I made you look at the Pavlov. I have to do the Pavlov stuff because you got to be able to talk Pavlov if you do PTSD treatment. All right. So once you've got people thinking this is possible, then you're in action stage. This is when you would actually do techniques. You shouldn't be doing any techniques with anybody before they're in action stage. And a lot of these programs, you get people in there and they just start throwing the interventions at them. No. So at this point, action stage, the question is, how do I change? Well, let me tell you how. We're going to do practice. We're going to do role plays about how to say no to a drink. You're going to have homework. You actually do these things. All right. It's not just telling about it. You're actually going to do these things. Say, how do I change? This is what we're going to do this week. This is what you're doing for homework. And then once you get them changing, then there's a maintenance stage because you're helping them think, well, how can I just keep this going? And that involves for PTSD, other things too, substance abuse, lifestyle change, support, things like that. So that is my view of stages of the change model. So, just in the interest of time, but I'm going to talk about the barriers to changing. You could think of the stages of change model as sort of, description of where people are at, but these are the reasons why people are at different stages, I think. Anyway, so the first one, as you remember, that slide I had the 4 things on. Those are 4 categories. So the first one is people aren't acknowledging a problem. So why would somebody not admit a problem? Why would they be unaware of a serious problem? Well, there's lots of reasons. Okay? They don't know what's normal, what's average. They have no idea. They grew up in a family, everybody's drinking and fighting and going to jail. So if you remind me, I'll tell you a story about something that I had no idea what was average. And, yeah, you have to remind me. You might not have to remind me. It's a good story. You'll like it. You'll like it more than most of my stories. So what they don't know, this is a whole field. I'm not sure I'm going to get into details with the slides that follow. I'm not sure I'm going to go too much into them, but we'll see. So there's a set of reasons now beside that, which is people, there are roadblocks, the word I used, to why you admit a problem to yourself. Why would you not admit a problem to yourself? Why does your grandfather not want to take his heart medication? I want you to think about that and bring it up in class. Why does he not take his heart medication? And then this is a little easier. There's a lot of barriers why you don't admit a problem to other people. And we'll touch on those things. Okay, so we're going to talk about, so this is just that first category. Now there's these 3 subcategories, and there's some details here. I don't think I'll go over a lot of them in detail. So for combat veterans, you got to look at like how'd they grow up? What's normal to them? And for combat veterans, they get what's normal or average from their childhood, from their pre-military experiences, actually just their pre-combat military experiences, afterwards. And sometimes, people have never seen anyone cope. I've had experiences where we did some social skills and someone said, oh, I never even thought I could just go up to that person and say, hey, I'm upset with you about this. I'm kind of angry. I want to talk to you. It's like mind-blowing to some people. They've never seen any adaptive coping models. So what they're doing is all they know. Why are they going to give it up? That's all they know. And this one you have to remind me about. It's a little longer. It's a great metaphor. I keep that in my head. So I have this stuff in my head all the time when I'm talking to people. I already told you got to walk in with a model in your head. This is part of my model when I walk in and talk to somebody. All right. So problems to admitting a problem to yourself. You don't want to think about what that means if you have that problem. Your father got put away for being, abusive of your mom. Well, and then you get accused of being abusive of your partner. You're like, well, I'm not like my dad. It's terrible. Don't tell me I'm like my dad. He was awful. Right. Survivor guilt's a big issue. People don't want to get help because they have survivor guilt. And again, so the bottom line here is that if you accept treatment, you have to admit the problem to yourself. So they're not going to accept treatment. Okay. And then the easier one is, why do people not admit problems to others? They don't want to be rejected, looked down upon. They feel guilty or shamed. They don't want to be judged. All right, so you look at all these. And this realistic concerns, very important. Don't get all psychological on people. Find out the absolute realistic things they're dealing with. Is it going to affect my job? For veterans or people in the service, they're like, well, is this going to go on my record? Is my commander going to find out about this? Usually confidentiality issues. They don't want their partner to know. Yeah, I'm not more depressed than I've told him or her. Okay. So there's a lot of reasons why people don't want to make problems to other people. So there's other ones. People, hey, I take care of myself. I don't need anybody helping me. Okay. There's actually PTSD avoidance symptoms. You don't want to think about what a mess your life is. If you think that you don't want to think about maybe you had a lot to do with it, instead of blaming other people, you start admitting things to yourself. There's a lot of pain behind it. And as much as I don't like personality as a concept, some people just have a general externalizing style. Everything's somebody else's fault. And let me just tell you, I see that in students. Not the majority, but the ones that are headaches, right? So the headaches for us, this is one of the headaches for us. I get somebody, no matter what happens, it's my fault they failed the exam. I mean, sometimes it's not quite so obvious, but it's there. Sometimes it is that obvious. Well, you didn't do this, and yeah. All right. For trauma victims, this would be interesting. We work with trauma victims. They don't often think they have PTSD. Now, they don't want to have nightmares. They don't want to be depressed. But you tell them they're too jumpy. They've got hypervigilance as a symptom. They're like, hey, I'm just being safe. I've seen the real world as it really is. So we can go through this if you want. Read it, see what you think. Okay. So this is why trauma victims, and this is true of any trauma victims, they tend to see the world differently when they've been traumatized, as more dangerous. Their judgment of the odds is off. Okay, so there's some data here. I'll let you read that. Cite my own work, of course. And this is all stuff, if you're interested in PTSD, I'll have you read. Now, the other thing you have to be very aware of, we're back to something that applies to you in counseling in general, is that people have a lot of fears about treatment. They think psychologists are weird, okay? They don't know what goes on in there. Again, they're just going by movies and TV. Analyze this. Have you seen Analyze This? I think all my examples are going to be ones you've not seen. I've not seen more current ones that are Netflix based or whatever. So, but they have a lot of fears of being forced to do certain things. I mean, there's stigma issues. I have to get mental health help. What? They don't know what therapists are going to do. So some research about that. Some vet specifics things I'll let you look at. And then more specifically, treatment expectancies, okay? What you always want to have a sense of when you start with a client is you want to get from them how much they think that therapy will actually work. They may not know, but they may think, well, Uncle so-and-so was in therapy. That didn't really help too much. Or I've seen those movies. That doesn't make any sense to me why it would work. Or my problem's too difficult. Or why would talking help? Or you haven't been through what I've been through. Why would that? So the expectancies are outcome expectancy and process expectancy. Okay? And you have to know, like on a 1 to 100 scale, you've got to ask the client, how much do you think this will actually work? And the other thing is, they may think it would work, but they don't think they can actually do what's necessary. This applies to homelessness. We've actually done research. I've got numbers on this from people low income who desperately need help, always at risk of financial disaster or at risk for homelessness, but are not homeless, maybe never have been. We have data on this. All right. What do they really think they can talk about their own personal feelings and those weird thoughts they have, or to a stranger? How much do they think they might think, yeah, therapy probably works, except I won't be able to do it. Again, 1 to 100. Okay. Credibility is a big issue. We're going to go over this beginning of next semester. So this is going to look familiar to you next semester, but I want you to have this in your head now when you walk, because you're going on practicum. You're going to be seeing people. How credible is that treatment? I mean, if you get a phobia treatment, what are you going to, some of the phobia treatments are graded exposure. So people going for spider phobia treatment, they're like, yeah, we're going to show you like pictures of spiders. What? See ya. I'm not paying for that. PTSD. Your treatment rationale and the techniques have to have some sort of credibility to the client. And you've got to ask the client how credible it is. I have sinus problems. So this one guy says to me, well, I think it's because you've got like acid reflux. And so here's a medication for acid reflux. I'm like, okay, thanks. I'm not seeing you again, pal. I do not have acid reflux. It made no sense to me whatsoever. All right. So, low self-efficacy is the phrase you need to use. What's the person's self-efficacy for outcome and for that they can do stuff? All right, research on this. You're going to get this next semester, all right? And then patient role expectancies. When you get somebody in there, they don't know. All they know is what? Where do they get their expectations about how to be a patient? From their medical experiences. And what is that like? You basically sit there and shut up. They ask you a couple questions, and they're done in 3 minutes. You'll hear more about that from me. Is the therapist supposed to be a doctor? Warm, nice, just, what are they supposed to be like? Are they going to be like those therapists on TV? There's data on this stuff. So, understudied, I did research on this. Non-combat PTSD dropouts reported lower treatment credibility. So they rated the treatment. This is non-combat PTSD, so I don't remember what they Taylor studied. I think car accident PTSD. That when they asked them ratings of how credible this treatment seemed, there was a correlation between those who had rated it lower and then later dropped out. Okay. And the big thing we're going to work on this semester is therapeutic alliance. And I'm going to have you read this carefully. This is the working relationship between the client and the therapist. It's based totally on the patient having a sense of trust in you and feeling understood and valued. This is all Carl Rogers stuff. If you don't know your Carl Rogers stuff, take 10 minutes and just look up something about Carl Rogers, okay? We're going to talk about Carl Rogers. Carl Rogers is a giant in the field of psychology. There are still therapy schools that are based just on his approaches. I'm a CBT person, but I believe that his approaches are critical for therapeutic alliance. Okay? Trust is only established not by you telling them how much you had alcohol problems or your mother did, by you listening in a very specific way. And you're going to learn that this semester. It's going to be painful. It's like this is like the boot camp thing. Okay. Therapeutic alliance is a well-established predictor of outcome. Okay. Some things to read if you want. How do you ruin your therapeutic alliance? Get into a control struggle with your client about what's going to be talked about. Client keeps avoiding talking about something, and you're like, well, let's talk about this. And get into a big control struggle with them over it. Patient says, I don't know, this therapy's terrible. It doesn't make any sense. I felt worse after last session. You're saying, oh, it's all right. Just, patient says, I didn't like the homework. No, you just got to do it. Let me go over again why you need. No, that's not what you do first. You might do that later. That's not what you do first. Active listening, empathic listening, reflective listening. Those are the techniques for a good therapeutic alliance. And then this, I think this is big. We're going to talk about how to do this. You address race, class, and gender differences between you and the client. You don't always do it. You don't always do it heavy duty. There's different ways to do it. You have to consider doing it with every single client. All right, this stuff you don't have to know. There's ways to measure this stuff. All right, so this is some of my stuff. So these are some methods. Now you got to keep in mind that what you're getting, this is a training I've done. These are trainings I do to other professionals. Because they stopped doing the fundamentals or they weren't trained in them well. All right. So basic counseling techniques, no matter what type of clinical or administrative interaction, I'm trying to get people to train their staff in this, the person who answers the phone. Your goal is always enhance patient trust, old school reflective listening with a little unconditional positive regard and warmth. Do you know how to be warm? If you can't sit in a room, and I'm going to tell you, when I do role play with you, if you're not coming across as warm, I'm going to say you are not coming across as warm. I want you to show some warmth. How do you do that? We're going to talk about it. If a patient feels listened to, he or she may also be willing to explore other roadblocks to them accepting that they have a problem. Do you see how this all ties together? True of any treatment. And I'm a big technique person. I'm a big CBT technique person, but this is just critical. You've got to know when, and I've done this in a group. Had a group one day, PTSD group, doing a research protocol, and they had to do this technique today and this day, and it was session number 4 or whatever. And they were all upset about some interaction one of them had with a VA staff person. And when a Vietnam vet, I dealt mostly with Vietnam vets, when they start getting angry, okay, we weren't doing any techniques that day. I was just going to listen. Don't be afraid to talk directly to your clients about things. It's okay for them to not like you or the therapy, and you have to give them that sense. This is some motivational interviewing stuff that we're going to go over in class. I want you to go through this stuff. That's all from the Miller and Rolnick book. Excuse me. And these are something, again, these are things I try to train other clinicians to do. You look like a genius when you start to treat your clients like this. I guess that's the wrong phrase from that movie. Remember that in the movie Do the Right Thing? That guy's always saying, do the right thing, do the right thing. Apparently that's the wrong phrase, but listen empathically first, correct misperceptions later if a client's got a misperception. All right? You have an open discussion. What might make you be unhappy here? What does it mean to you to have a mental health problem? This is where you're going to find out their ambivalence is the word you're going to start using. How ambivalent is that patient about A, their problem, about having a problem, and B, about getting help. All right. And we're going to talk about motivational interviewing in the course. This stuff is all my particular Frankensteining of it and some new things, but you know, my work, I'm always standing on other people's shoulders. You know what I mean? We stand on the shoulders of giants. Have you heard that phrase? So, you know, people have really done major work or have major creative ideas. So this is all a lot of my stuff that I've actually done. And then I did a second version of this group for a study at Detroit that they asked me to they wanted to use my methods. All this stuff you don't have to do. But like this stuff you might want to take a look at because this is going to be related to your paper assignments. So take a look at it. All right. Basically ways to ask and assess all these things. I think that's pretty much it. These are some fears about why people don't change. I'll have you take a look at that. Should make sense. So take a look at all those. We can discuss them. Those are fears of why people don't want to admit a problem to themselves, other people. But these are all things you can ask people. There are ways to ask them this. All right, questionnaires. And like I said, I've done research on this stuff. And I'm doing research on this with grad student and undergrads about the extent of this among homeless. We reported data about this with low income and homeless got accepted at a conference. So the stereotypes thing, take a look at that. Okay, getting towards the end here. So these are just different sessions, I think. So I think I'm going to end the show and we'll go down here. I do want you to at least look over this stuff. This is all how I've done the intervention. This is the way you ask people about their self-efficacy, the outcome in the process. 1 to 10, how confident are you that you will be able to do what's necessary? And on 1 to 10, this is process stuff. So expectancy, 1 to 10. And then there's also a question, you know, how much do you think this will work? All right. You've got to assess people's realistic barriers. Why they're not accepting help? Oh, they don't want help. Well, you know, maybe they've got financial issues, childcare issues, transportation issues. And let me tell you, this is a huge one. A huge one. If you ask me what's the main reason why there's so much homelessness in the United States, it's because of bureaucracy. And in Florence, there are oceans of red tape. And I do say that to my buddies in nice ways. Some I don't say it in nice ways, but when I'm dealing with big organizations. So anyway, other things that we assess and ask about. And I like this. This is a phrase actually from AA. You go fast by going slow. You want a patient to get better in a reasonable amount of time. You go slow with them. Okay? So we'll talk about all that. So that's basically it. Hope that is helpful. And we're going to start to talk about those things. I think mainly stages of change, a little bit about the expectancies, and then we're going to get to the motivational interviewing stuff more formally later on. I hope you guys are having a good day, and we'll look forward to seeing you again.